Hello, everyone, and welcome to our session, which we hope will be very interesting. My name is Willibald Zek. I'm the Global Maternal Newborn Health Thematic Fund Coordinator, and I have the pleasure to co-chair this session together with my colleague and friend, Alison Moran, who's the maternal head, or the head of the Maternal Health Unit in WHO. The aim of our session is, to discuss and to see how we can strengthen maternal and perinatal death surveillance and how we can respond in a strategic way to reducing maternal and perinatal deaths within the scope of MPDSR. And so we really want to give an overview with this presentation, give you the latest evidence, and then maybe also a little bit of country experience. And with this, I would like to hand over to Alison to kick off the presentation. Over to you, Alison.
Great. Thank you very much, Will. And it's a pleasure to be able to be with you today to talk about maternal and perinatal death surveillance and response. So I'm going to just give Will and I are going to give a quick overview for the session to really talk about what maternal perinatal death surveillance and response is, some of the latest evidence, and share with you some of the materials and guidance that are available. So first, I know you've seen a lot of this throughout the opening forum, but just to refresh that we know maternal, perinatal, and neonatal mortality is a huge burden, especially in lower and middle income countries. So we know that about 810 women die each day due to complications of pregnancy and childbirth, that approximately one stillbirth occurs every second for about 10 million stillbirths every year, and approximately 2.4 million newborns died in the first month of life. So it's a huge burden, and we need to really look at different approaches that we can use to address some of these issues to reduce mortality and also reduce morbidity, disabilities, and long-term ill health. So what is MPDSR, or maternal and perinatal death surveillance and response? It's a continuous cycle of identification, notification, and review of maternal and perinatal deaths, and followed by actions that are put in place to improve the quality of care to prevent similar deaths that might occur in the future. So the S piece is really looking at surveillance and active reporting of all deaths. The R piece is looking at the response piece and what actions are taken. And it's very important that we assess the modifiable factors that could happen as well at the community and the facility level. So here's a graphic of what the MPDSR cycle looks like. It starts with identifying the deaths, and that could be done to strengthen the civil vital registration systems, reporting the deaths, which can be used for tracking maternal and perinatal deaths, reviewing the deaths to really look at improving the quality of care measurement, and then importantly, responding to those deaths through quality improvement and other processes. So the latest evidence on MPDSR is that it can be quite effective at improving maternal and perinatal outcomes, especially if it's implemented in a quality way around especially looking at training of staff at all levels of the health system, and to really try to reduce the issue around blaming providers for deaths that may have occurred. It's a complex intervention, so it's very important that all the different pieces are put in place and that local leadership and training is crucial. And we really need to have more research about how to include community-based death reviews into the processes for collective action. So we have developed what WHO and partners, including UNFPA, UNICEF, and many others, a variety of different resources that can be used to really strengthen the implementation of the MPDSR approach. So there is technical guidance that looks at how to implement maternal death surveillance and response, as well as looking at death reviews and response for perinatal deaths through the Making Every Baby Count guidance. There is guidance around how to classify both maternal deaths, the ICD-MM, as well as classifying perinatal deaths, ICD-PM. And we are in the process of finalizing guidance around operationalizing MPDSR and improving the quality of the systems and the processes with a variety of different resources and tools through this operational guidance document. which will be finalized by the end of this year. So just to say that MPDSR approaches are very popular and many countries are in the process of implementing them. So in the WHO policy survey that was conducted in 2018 and 2019, you can see here of the 155 countries who responded to the survey, that 80% or so have a national policy or guideline requiring notification of all maternal deaths within 24 hours, as well as reviewing all maternal deaths. In addition, globally, about 70% of countries have national policy or guidelines requiring review of neonatal deaths. But as you can see with this, in the third string of bars here, looking at national policies or guidelines around requiring review of stillbirths, that less than half of countries who've reported in this survey have those policies in place. So we really need to strengthen that area to ensure that we better understand what's the causes and what's leading to these deaths of stillbirths. And you can also see here in this graph the variation by regions, and there's quite a bit of variation as well. So based on some research that colleagues have done, there are a variety of gaps and challenges around implementing quality MPDSR processes. One is around the quality of the reviews and coding causes of maternal and perinatal deaths, as well as varied documentation and implementation of the recommendations and the response. There's really, in some places, poor linkages between MPDSR audits and quality improvement processes, which are essential, as well as lack of linkages between MPDSR data and what's included in the routine health information systems. In addition, there are issues around how the response and the recommendations are implemented, as well as various human and financial resources gaps and challenges. So now I'm going to turn it back over to Will to talk a little bit about maternal death notification rates and finish up the presentation. Over to you, Will.
Thank you, Alison. And just to say that, we wanted to bring a little bit of what's happening at country level, and in UNFPA, we have reviewed the 32 countries where we work within the scope of the Maternal Newborn Health Thematic Fund, which is the UN member state funded program. And our findings were really that there is, only 1/3 of expected maternal deaths are being notified, which is rather low. That means probably in some countries there's a low implementation of MPDSR programs in countries, but also the risk of bias by analyzing maternal death trends and causal trends. And you see on the graph here how the notification rate is on off, going up and going down. So our conclusion is we need more efforts, more support, and we also believe that with COVID we might have even more problems with notifying. So we really have to stay alert, and we have to be very vigilant so we know what's going on at the country level. And so just to say, MPDSR can really improve healthcare systems. It's a tool that can strengthen health systems in general, but it's also very important for creating a no-blame environment and to retrospectively look at errors and mistakes that have happened to learn from them. And we really believe it's a great tool that we have to further work on and build on. Yes, and here are some references for where you can find more information. And also just to say, it's not only WHO and UNFPA, but so many partners who are working on that, as we are here in other presentations. And yes, we hope that we can broaden the base and get more and more partners on board to support this endeavor. Thank you so much.
Thank you very much, Will. And now we have the honor and pleasure of welcoming Mary Kinney to give a presentation on a scoping review that was conducted to really look at lessons learned around implementation of MPDSR in 24 countries. Mary Kinney is a health policy and systems researcher at the University of Western Cape's School of Public Health in South Africa. Her PhD research is focusing on implementation of MPDSR. Mary, welcome.
Thank you, Alison, and thank you all for having me today. I'm giving this presentation on behalf of a team from the University of the Western Cape and Makerere University, where we partnered to do the scoping review on behalf of the Countdown to 2030 drivers group. And we're really grateful for all of the partners, including the MPDSR Technical Working Group, for the inputs and the consultation process that was underway for the scoping review. I'll briefly speak about the scoping and review approach and the conceptual framework, but spend most of the time talking about the findings in relation to the implementation practices, and then some concluding thoughts. If you would like more details about the methods or the framework, you can look at these open access papers that are available online. So why did we seek to undertake the scoping review? Well, as we heard, there's really been growing momentum to strengthen and expand and study the intervention. And this is a complex intervention process. And so many of the studies that we've seen, and even the reviews that have been done already on implementation factors for MPDSR, tend to look at more static implementation factors and don't use a theory-based conceptual framework. We also found that none of the reviews actually included both maternal and perinatal death surveillance and response, and did not include all low and middle income countries. So there was a gap in the literature that we wanted to address. So we set out to map and synthesize the available literature to identify and describe factors that support or hinder implementation, and to develop a conceptual framework that considers the critical dynamic linkages and triggers of change for which we could use to analyze the data. Through a systematic screening process, and you can see some of the methods in the boxes on the side, we identified 1,027 studies, and through a screening process identified 72 resources, of which we collected data and analyzed that data, and that included 58 primary studies. The theoretical framework that was developed was adapted from the Consolidated Implementation Research Framework, and as you can see here on the left, it considers the different levels of implementation. And we have what we have in theory, what we want implementation of MPDSR to be, versus what's actually happening in practice. And we considered these 4 domains as areas in which are influencing implementation. And I'm going to briefly speak to each one. So the intervention are the characteristics of MPDSR. And this includes the content components of the audit cycle, but also elements of piloting it and trying it out and finding out how it works. In terms of the next domain, we looked at individuals. So these are the characteristics of those who are involved in the implementation, their skills, their knowledge, their motivations. We then looked at the outer settings. So these are factors that influence externally the implementation. These can be resources and policies, as well as external actors and political pressures that can enable or hinder implementation. And then finally, we looked at the inner settings. So these are the factors that are internal to the organization, things like team relationships and implementation climate. In addition to these 4 domains, we also looked at the different ways in which we can understand these factors. So this builds from the Countdown to 2030 drivers group work, looking at understanding health system drivers for women's and children's health. So you can see the shading of the different components of each of the domains aligns with the different lenses. So the ones that are in light or in dark gray are the service delivery lens inputs. So these are things, tangible inputs that we need for implementation. And these are the things that WHO and colleagues are already measuring and tracking. The black elements are those that are from the societal lens. These are the interactions between those involved in the implementation. And finally, the light gray are the systems lens elements. And these are things that trigger change. And overall, we had 24 constructs. So in terms of the key findings of the records themselves, of the 58 primary studies, there were from 24 low and middle income countries, mostly from sub-Saharan Africa. There were few from Southeast Asia and very few from the humanitarian and fragile setting, only 4 countries in fact. And what we saw was most of the literature focused on maternal death review and MDSR, and it looked at a combination of levels. There were very few studies that focused on the meso only, or the micro only, or the subnational only. And then most of the studies were qualitative and were led by academia in partnership with government. And we had 600 data points that were extracted across these papers. That data was analyzed. And for the outer and inner settings and the intervention domains, we saw about comparable amounts of data, but the individual domain had the fewest data points, only 13%. And the overall findings, kind of key takeaways, is that most of the studies described tangible inputs. So these are things that were addressed by the service delivery lens, but these were often measured inadequately and through non-comparable ways. And while studies document the belief that people have that implementation leads to change, there was really little evidence presented on the closing the loop in terms of the actions taken. Studies state that people and their relationships, including their motivation, the implementation climate, and the ability to communicate influences implementation processes, but actually the individual subjective experiences and their relationships themselves were inadequately explored. And MPDSR implementation contributes to accountability and benefits from a culture of learning, but really few studies investigated the change dynamics involved. For the intervention domain, there was really inconsistent reporting across the different steps of the audit cycle, as described by Allison, with very little on notifications and on the response. And we found that there was no difference in implementation factors by the different types of reviews. So maternal or perinatal or obstetric audits that we identified, there was no difference in the findings. In terms of cost, this was identified as an input for training or transportation, dissemination of results, and meeting for human resources, but very few studies actually report costing data. And when they do, there's no standard approach to compare. The framing of the intervention source and the intervention evidence strength was explored, but nothing about relative advantage. Countries are clearly adopting from the WHO guidelines, but in terms of understanding the different contextual changes from policy to practice, those are not being documented or examined. And stakeholder legitimacy is not explored. And some of the literature, as I said, indicates there's a belief that it works, but little evidence to indicate it does. The phasing and pilots were used. We identified 9 pilots, and local leadership was a clear enabling factor. But there was nothing reported on the modification or expansion of these pilots, showing really a challenge of sustained implementation beyond projects. And we also identified that the process has adapted and changed over time. So the intervention has shifted over time as well as implementation processes. But in fact, we're not really applying the learning that we have from previous literature. So the learning and the recommendations that we saw in the literature in the past 5 years was very similar to what we saw from over a decade ago. In the individual domain, there are skills, technical skills that are required and were identified, but there was no clear list of required competencies that are needed. And very few studies actually measured technical competencies of those who are practicing MPDSR. And again, when they did, they weren't comparable. The individual competence to implement MPDSR is supported by supportive supervision, appropriate tools, and oversight from subnational management or other health specialists. And this is also linked to motivation. So the extrinsic motivation is really that expectation from the subnational team. So they want to demonstrate that they're doing this work, but also the skills or knowledge and incentives are extrinsic motivations. And then there were the intrinsic motivations that came out in the literature as well, the consciousness for self-improvement and the value of life, the maternity consciousness. And then individual perceptions of the MPDSR process, they were described. People said they were helpful, particularly for learning, but very few studies looked at the ownership or their commitment to MPDSR and what would have caused that. And maybe it happens over time that people see the benefits of change and then that ownership comes, but that really hasn't been documented. And individual orientation to collaborate, and we know with MPDSR, there needs to be a lot of people involved for collaboration. This wasn't explored at all. In terms of the inner setting factors, there are clearly inputs that are needed for implementation, and that's invalidated by the scoping review, such as focal persons or regularly scheduled meetings, audit charters, available tools, but often these are listed as more static elements that need to be in place without the interactions involved. And the teams are described as multidisciplinary as per the guidelines, but challenges remain, which I think we're all too familiar with, including high staff turnover, competing priorities, lack of interest in hierarchy. Incentives are mentioned in terms of trainings, per diems, refreshments, but none of them are investigated for impact. And there was nothing that we found in terms of consequence or sanctions for not implementing audit. The team approach in organizational culture, though, is a critical enabling factor. So having a culture of accountability, learning, and improvement really is going to enable implementation. The blame culture was something else that came out strongly in the literature, often perceived as a barrier with some mixed results. There are some great papers that actually demonstrate an enabling environment that prevents blame and shame and name. And so I think we have to also look at some of those papers. And one of the modules in the operational guideline is going to be specifically looking at the blame culture. And then finally, engaged leaders are recognized widely as enablers. But yet it's just not about leaders. It's about knowing what are the skills necessary to ensure that leadership. So what are their traits, and how do we ensure that we can support others to have those traits? Critical thinking, for example, problem solving. Facilitation was one identified trait of these leaders, but not investigated specifically. And finally, for the outer setting factors, policies and guidelines were in place, but we found few studies that looked at the legal frameworks or protocols around death notification. Funding sources are mostly from the government and developing partners, but a lack of a budget line was identified as a barrier. Although there were mixed results on this, because there was some argument that you don't need to allocate specific resources for MPDSR as it's part of clinical governance and other aspects. So again, this requires further looking into, and perhaps it's a contextual factor. The important role of external actors came out as a strong enabler. Development partners, professional associations, civil society have a critical role in helping to develop guidelines and support implementation. And then at the facility level, the subnational actors have a really important external role for supporting implementation through supervision. And then pressures to implement really depends on the level of implementation. So at a national level, those political commitments are an enabler for implementation. At the facility level, the subnational structures, for example. But very few studies actually investigated the perceptions around why or how those pressures are working. And one thing is clear from this whole study is showing the interlinkages across the various domains and the constructs, and that's so critical, having that network, because better data and reporting will improve communication across the health system, as well as between team members, and that strengthens the team. So this is all a continuous process, and that's why in the framework you see it as a circle, because it's all feeding into each other and linked. Because MPDSR is a complex intervention process. And so by using this theory-based implementation framework, it really helped us to unpack the various components needed for implementation. And we would challenge that moving forward, we think we should go beyond what we think we know works. So do we know enough about the blueprints for implementation? And what do we know about how to sustain the process, particularly in systems that are under strain or have many different competing priorities? And then I think generally as a community, it would be good for us to do better to comparably learn what's working or doesn't for MPDSR implementation, because it was really difficult because of the different approaches that are being taken. And then finally, there are a lot of research gaps, especially around the individual perception and skills needed, the subnational level engagement, which we found really is a critical enabler in terms of implementation for accountability, information flow, and quality control, but very understudied. And then adoption, including the humanitarian and fragile setting. We saw there were only 4 countries that had papers that included studies. And we know that this is a critical area to move forward as the burden is highest in these settings. And as part of the technical working group, there is a subgroup that is focusing specifically on humanitarian and fragile settings. And they've done a landscaping review and are undergoing implementation studies now. And we really look forward to learning more about implementation practices in those settings. So health policy and systems research looking at how and why people adopt, adapt, and sustain collective action will strengthen our understanding of implementation of this complex implementation process. And I would encourage you, if you're looking to do further research on implementation of MPDSR, to have a good look at the scoping review, to identify where those gaps are, because there has been a lot studied on in this area, but how can we do better in our collective research and approach moving forward? Thank you very much, and the paper is available online at this link.
Thank you very much, Mary. And now I'd like to introduce you to our next speaker, who's going to talk about community-level implementation of MPDSR in Bangladesh. And we're pleased to welcome Dr. Animash Biswas, who's working at UNFPA Country Office in Bangladesh as a technical officer, and he supports the national MPDSR system in Bangladesh. He's a medical graduate and a doctorate. His doctoral research was on the maternal and neonatal death review system, and he's been contributing to NPDSR in Bangladesh and globally over the past 10 years. Please, Animash, welcome.
Thank you, Alison. Good morning, good afternoon, and good evening to everyone. So I'm going to present community level MPDSR in Bangladesh, the experiences and lesson learned. So what the MPDSR content is a facility part and as well as community part. For this presentation, I will focus in the community part. The presentation is outlined as a background, and I will talk about the community identification and notifications, then community death review and cause assignment, community responses, and then community engagement in MPDSR. Finally, I will talk about the lesson learned from Bangladesh context. So why community MPDSR is really important? So as the previous presentation, Alison mentioned about the importance of community MPDSR. So significant number of deliveries still are taking place at home or on the way in many of the developing countries. And most importantly, the vital registration system is inadequate to capture those deaths. So therefore, there is a several underreporting or there is a misclassification. And definitely there is a, hard to reach areas and living behind community is very difficult to get the death where it occurred. So mapping of the death is really important for us to know where that dense area is, to where need to intervene correctly, and then we need to know the delays and social challenges in the community level. Moreover, the community engagement is very important in the death review process and responses. So therefore, if we really do the community MPDSR, then we can get those opportunity to explore the causes of death. At the same time, we know the social barriers and gaps to intervene timely and responding to those deaths. In Bangladesh, the MPDSR has started back in 2010. It was piloted in one of the districts and gradually scaled up by 2015 in 14 districts. The experience was really good, and we able to capture the deaths, we able to identify the causes of deaths, and some real time responses were taken by the committees. So therefore, the Ministry of Health and Family Welfare has planned to scale up nationally. So with the support of different technical agencies like UNFPA, UNICEF, WHO, and other relevant partners. So Ministry of Health and Family Welfare, they published several documents, included the National Guideline, Manual, Tools, and Pocket Handbook on MPDSR. And MPDSR has been included in the 4th operational plan of Director General of Health Services. Currently, it has been implemented in 48 districts out of 64 districts of Bangladesh. That means the majority of the part of the country has been covered in MPDSR system. So if you look at the MPDSR implementation framework, as I talk about the community MPDSR, although this framework is community and facility level, in the community level, if you see in the right side, there is a, at the community level, health are, data reported by health assistant and family welfare assistant who are working at the government field level health worker. So they reported the death and they do the death mapping. And following the data reported, the verbal autopsy and social autopsy is done by the health inspector and family planning inspector, assistant health inspector who are working in the government. So they do the verbal autopsy, they do the social autopsy, they bring the causes of death by doing the verbal autopsy, and they explore the social barriers and social gaps and stigmas related things from the social autopsy and bring some solutions. So that comes to the review committees, and discussion take place in the review committees. which is the quality improvement committee in the different tier, and the sub-district level and the district level, and then national level. So national level, there is MDRSR core committee who are responsible to take care of all the district and sub-district level decisions and properly timely response to that. So now I'm going to share the community level MDRSR, the time cycle of different component, which I have mentioned earlier. So death is notified within 3 days. That is done by the grassroots level health worker at the community level, and that is reported in the system. Following the death notification, the verbal autopsy is done by the health supervisor. That's been the health inspector or family planning inspector. So they go to the household and discuss with the deceased family and collect the information from the community level. Following that, after the verbal autopsy is done, social autopsy is done by the same health worker at the community level within 15 to 30 days. Cause analysis workshop is done periodically in the district level or in the divisional level as needed. And then evidence-based action plan is taking based on the cause analysis workshop and the findings. So those are the continuous cycle are taking place at for the community level MDRSR. So following that, I am going to share some of the important aspect of death identification and notification. As I said earlier, the government level health worker do the death notification. They use the community network. So as they are working in the field level, they working in the household level, but at the same time, they use the community network, different, community group, community support groups, and different stakeholders at the community level. They use their network and their support to get the information from the community level. So they use a death notification slip to fill out if any death information is collected, and they report back to nearby community clinic, which is primary center, and the data is uploaded from the community clinic to the DHS2. And monthly reporting is performed at the sub-district level. This is a primary healthcare center. It's named Upazila Health Complex. So every month, deaths are completely reported in the community clinic, at the same time in the sub-district level. So in case of the death review, after the death notification is done, as I said earlier, the health supervisor, that's mean health inspector or family planning inspector, go to the community and do the verbal autopsy with the deceased family members. So health supervisor use a structured questionnaire and explore the causes of death, contributing factor, and the delays. So one important aspect is, as this is a one-to-one interview session, the written consent is taken for before each of the interviews, and one of the most important thing is the non-blame culture is maintained and confidentially data also kept. So in case of the cause assignment of community deaths, since this is a information coming up from the family members of that deceased family or relatives, therefore it's very important to identify the causes of death from that verbal autopsy form. So each of the verbal autopsy form is reviewed by the consultant, either is gynae ops consultant or neonatologist or pediatrics, and assignment of the causes of death done based on the ICD-10 code. And at district and division level, they organize the periodic cause analysis workshop, as I said earlier, and finally the cause of death data enter in the DHS2 system later on from the district or divisional level. Then what I mentioned, the next step is about the social autopsy. Social autopsy basically stands for community self-diagnosis and identification of modifiable social and cultural factor in the community could and represent as a response. So social autopsy is not a data-driven thing, or is not a tool to use for the collection of lot of information. Rather than it create an avenue for understanding the community demands and knowledge gaps and challenges that they need to be overcome by the community. So this is a interactive session. It is a session for the community. Some community can come up with their own barriers and challenges, so they can identify what they need to know, what they need to do to rectify themselves to if there is such situation come again in their particular community in future. So community engagement and community participation are very important. This is one of the priority area which need to be addressed in MDRSR. What Bangladesh experienced, that it really built knowledge through dialogue and discussion, because community come to know different context of that death, why death happened, what are the barriers was, what are the things need to done, and what they didn't do, but which is a opportunity to do in the next. So this is a knowledge building session. At the same time, this create enable environment for self-understanding, realizations, and that empower the community, and community leadership also grow because the presence of the community leaders and presence of some of the elite person in the community, they take the ownership of that particular community to take responsibility to avert such type of death in future by their great initiative. So increase commitment and accountability, because this is a interactive session. They discuss among themselves, they prioritize their need, and they identify their points which can be corrected. So this is the action point which is doable, which is feasible by the community. So and therefore the demand setting for quality care is also improved, because community understand that where need to go and how to go, when to go. So that give avenue to improve the demands for seeking the quality care. And the improve referral linkage also, because they know that how to go and what initiative need to take before such things happen. And avoiding of blame also came up during the community engagement and participation. So quality aspect of community MPDSR, what we exercised in Bangladesh, the periodic district review workshop that give avenue to continues to do the discussion, as well as the divisional level workshop, monthly coordination meeting in the district and sub-district level, presence of the district and sub-district MPDSR focal person, that person take the leading role of the district or sub-district level and take care of the data. And midwife engagement in the community MPDSR, we try to exercise in some of the places as a pilot. So to see that whether there is a more involvement of the midwives can give the quality information to the community. Video conference from the national level with the districts is a new initiative by the government with the support of us, and that giving opportunity to have discussion with the district, with the and the national level, Ministry of Health people. So that gives plenty of scope of discussion and a scope for the taking some of the real-time intervention on initiative or action based on need. So that can come up, and an annual a national report on MPDSR, and another aspect of giving or sharing the quality informations on community MPDSR. So lesson learned from what we learned from doing the community MPDSR in Bangladesh, that community MPDSR is really needed for a country like Bangladesh to capture the death, particularly mapping of the death, to know that where the death dense area, where the pocket area is, identifying the causes and immediately respond to that causes. So again, the community engagement is essential, what we have found, and active participation of the community is really works. Social autopsy in the community is a health promotion tool and a prevention tool for the community. And that definitely help us to reduce significant number of maternal and newborn death. However, strong commitment, accountability, and monitoring are needed to achieve the quality data and response. Finally, before I conclude my presentation, I would like to acknowledge the Ministry of Health and Family Welfare, particularly Director General of Health Service and Director General of Family Planning, Quality Improvement Secretariat of Ministry of Health and Family Welfare, UNFPA, UNICEF, WHO, and the relevant stakeholders who are closely related with the MPDSR implementation in Bangladesh, including the professional society like OGSP. Thank you.
Thank you very much for listening, all of you. We have unfortunately only 8 minutes for questions. So what I will do is now, we have very thoroughly followed your comments. We have tried to address them, Mary, Animash, and myself. I tried to lump a little bit the main questions, and so the panelists can reply to them. And I felt that One bigger question was around how we can triangulate and bring everyone together on MPDSR on a healthcare facility level, you know, integration of quality of care, HSMI, and data, but also all together. So I think it really plays into the multidisciplinary question. And I wanted to ask you, Mary, what is your view on that? And what did your study show? What's your experience? How can we bring this all better together? Quality of care, MPDSR, but also data around that at healthcare facility and even at national level.
Thanks, Will, and I really appreciate the discussion in the chat. So in terms of the multidisciplinary engagement, that really came across as a kind of core aspect in the scoping review, with most studies mentioning this and noting that the review process involved a variety of cadres, both at the facility, but also external stakeholders, from Ministry of Health and implementation partners at the subnational and national levels. Restriction in terms of participation was reported as a barrier in some studies, especially when there was low participation of support staff and nurses or even management. So having senior management at the meetings we know is really important as an enabler, because they're often the decision makers or interface with subnational decision makers and other management to help ensure the actions take place. So that is a really critical aspect. In terms of engagement and participation of nurses and midwives, which are critical in the process, one pilot study actually was over a decade ago, actually tried to implement first with the nurse midwives to establish a culture of evaluation in a blame-free setting and to broaden the membership out afterwards. And what was interesting is that they found that they were more comfortable with the practice, but they were still shy. I mean, the hierarchies, I think, in the health system really are something that we really need to unpack further. And having a culture of kind of learning linked to these meetings is really important. And also in terms of multidisciplinary, we also found that there's some evidence of participation of specialists, particularly at the lower level. So, someone from the referral level coming in is able to kind of make it much more about the kind of education and the learning around a case rather than the individuals involved. In my own kind of study right now, doing my PhD in case study research in South Africa, learning it's very different in different facilities. Having it embedded within the health information system, I think is really something that's coming out in that research as really an important factor for sustainability. So ensuring that the data managers are involved in the process, not something that you oftentimes see in the committees in the formulation, but if they're engaged and they're part of the reporting process, it does allow that ownership. Thanks.
Thanks, Mary, that's great. I hope that answered some of the questions. I wanted to turn to Animash, and I saw that a few colleagues or in the audience, there were questions around community engagement. I think you exactly brought that to the table. My question to you was, what is your exact experience on blame culture? We had one question in the chat where someone was saying there's experience that sometimes doctors and midwives blame the community. Do you have some information on that? And then also, there's also a lot of chat around perinatal deaths. Is there also a blame culture in terms of perinatal deaths in the community or in the health facilities? How does this play out, Amish?
I think, thanks, Will. It's a really important question, which is important in a sense in the community part, because community always there is a chance. What I also mentioned in Tanzania, they have experienced the blame issue, but it's more related to some of the key important area which need to be addressed in Bangladesh. What we experience, like one thing, engagement of the health managers and the policy makers. That is very important, because if they ensure the healthcare providers, if they report any death, there will be no issue of blame. That's the healthcare providers' perspective. So that is very important. So role of the MPDSR focal person and MPDSR committee is very important to ensure that there is no blame issue will come up. And second thing is capacity development of the health workers is secondly very important. Without having that strongly come up with the blame culture issues, they cannot do the notification properly. Come to the community. So what we experience particularly, because our health worker is the government health worker who are working in the field level. So they have a very good connectivity with the community in a small catchment area. Since we have a very primary center located with the 6,000 population is called community clinic. Is a day center type of thing, only providing service in the daytime. So therefore, there is a good connectivity with the community and the health workers. So they continuously do the advocacy, and in the community clinic, there is a community group and the support group. They are functional. They have an existing committee who run the community clinic from the community side. So they have some leadership, and therefore there is some accountability issue came up to reporting the deaths. So they interaction with the community, with the healthcare providers, and their engagement ensure the the notification properly and reducing the blame in the community level. So what we experience in Bangladesh, but it is really differ from context to context.
Thank you so much, Animash. And I would love to continue discussing, but I just hear from the organizers we have to wrap the session up. I think it was really, really interesting. I hope it was also interesting to you. We also noticed very well your questions on the P in MPDSR. Just to reassure you, all three of us and all who are in part of MPDSR very much want to highlight the P, and we will continue working on the P. Yes, and I think that's it from my side. I see the organizers say 1 minute left. Thank you so much for joining, and we hope to see you soon in person. I think this will be the biggest wish for many of us. Thank you so much, and see you. Bye.